Hi, my name is Richard. I'm a speech and language therapist and a lecturer based in the UK. In today's video, I'm going to talk about clinical placements. In a previous video, I explained that I completed my degree in speech and language therapy at Newcastle University, and this took 4 years. Now, in terms of placements, in the first year, there weren't any placements. There were opportunities to observe peers whilst they were on placement, but all of my placements came in my second, third, and fourth year. So my first clinical placement was actually on an on-campus placement in the university's aphasia clinic. So this gave me an opportunity to work with several other undergraduate students and master's students. So this was a peer placement, and we worked together for approximately 11 weeks. And we had a timetable where we worked with a particular number of clients, and for me, I worked one particular day where I saw clients back to back. So I worked with 2 adults with aphasia, so one who had really quite severe aphasia and had difficulty even at single word level, and then another person who had perhaps a more mild aphasia and difficulties at maybe sentence or paragraph level. So this gave me an opportunity to develop skills in assessment, so kind of delivering different kinds of aphasia assessments, both formal and informal, and then also obviously doing lots and lots of therapy and handing over the results and designing tasks, both for myself and then also for my peers in the team. So the patients themselves would be having individual sessions with individual students, and then they would be taking part in group sessions as well towards the end of the week. So the patients who were coming onto campus were effectively having what's called intensive aphasia therapy. They'd be seen several times a week, and often they'd be travelling quite significant distances to access this therapy, often because they couldn't get access to this in the NHS anymore, or they were having to pay privately, for instance. My second placement was again another on-campus peer placement. This time it was myself and another undergraduate student, so just the 2 of us, and we saw a child in the literacy clinic. I saw them for 1 day, and then my peer saw them for another day, so the child was seen twice per week. And again, this was after school, so the child's mum and dad would bring them to clinic between the hours of 4 and 6, and I would kind of do some assessment, do some therapy over the course of 11 weeks, and again I'd be handing over the results of my therapy sessions with my peer, and then vice versa. So it was quite a dynamic, interesting kind of working relationship. Now, one of the things that was quite interesting was, again, when we were doing therapy sessions in my particular room, we had a 2-way mirror. So I would often have, because I would be starting my sessions the earliest of anyone in the clinic, I would have the child's parents watching, I would have my clinical supervisor, and then sometimes other students as well, which was a bit nerve-wracking to begin with. But what was quite interesting about this placement was the fact that we got a chance to go and see the child in school as well, and have a chance to talk to the child's teacher, and to perhaps see what the difficulties were like in the real world, what the functional impact of this child's literacy difficulties, and try and unpick some of the language and speech issues that were often underpinning the literacy difficulties as well. In my third year, I completed my first off-campus or external clinical placement. So this was for 6 weeks. It was 1 day per week, so I was still studying at the same time. And it was on a stroke ward in a hospital which was just opposite my university. So again, no difficulties from a commuting point of view. And again, the working time was very similar to what I was doing at university anyway. I was by myself this time, so it was kind of shifting away from being with my peers and just being with a stroke clinician, who sometimes went on different wards as well, but we were primarily on the stroke ward. Now, being on the stroke ward was really quite an interesting experience, because for me, it gave me a chance to attend lots of multidisciplinary meetings. So I got a chance to kind of observe and interact with lots of professionals like doctors, dietitians, nurses. I got lots of opportunities to shadow other professionals as well, so things like physiotherapists, radiographers. I got a chance to observe video fluoroscopy, so x-rays of people swallowing. So I went to a different hospital for that. I also went in on a non-clinical day actually to observe a aphasia, which is a camera which gets inserted in your nose and looks at you swallow down in your throat. And again, I did that because that wasn't an opportunity that was available on my clinical day, but it's something that I wanted to kind of see in real life from my learning point of view. So I went in on a non-clinical day for that. it gave me a chance to do lots of informal assessment. Obviously patients were quite ill and unwell. They've just been admitted from usually having a stroke, or quite unwell if we went on a different ward from infections, or maybe they'd had a fall, things like that. What I found particularly challenging about this placement was the fact that I'd done a lot of my communication teaching, so things like aphasia, dysphagia, apraxia, so I kind of covered most of that by then. But being in an acute hospital, there was a heavy focus on dysphagia or swallowing difficulties, and I hadn't done any of that teaching yet. So a lot of my learning around that was kind of done on placement itself. It was kind of being exposed to it and kind of being given some directed reading by my clinical educators and them talking through things, which was really quite helpful. Whereas with some of the communication stuff, I could be a lot more hands-on and end up kind of developing some therapy materials for patients who had communication difficulties, which then I either did myself or the team had a speech and language therapy assistant. So again, I developed like a program for somebody's dysphagia, so kind of speech difficulties, and the assistant was essentially, on the days where I wasn't there, they were kind of following the program I'd kind of written and designed, which is quite nice. But yeah, it was a challenging placement because again I felt like I hadn't had some of the teaching going on to the placement, but the clinical educators were quite accommodating around this, and we kind of just learn on the job. And interestingly, the clinical educator that I had for that placement then came in my fourth year and was then the one doing the dysphagia teaching around things like stroke, which was quite nice. So again, it was a chance for me to reflect on what I kind of learned on placement. My fourth placement, so this is my second placement in my third year, was my first block placement. So this is a full-time placement which took place over the course of 6 weeks, and so full-time hours over 6 weeks, and I was split between 3 clinical educators, and again this was a peer placement. Part of it was by myself, and then other parts I did with my peers, so they would be observing me and vice versa whilst we were doing our sessions. The placement itself was a community paediatric placement, so I had opportunities going into different community settings. So one of the days with the clinical educator was very much kind of assessment or kind of dealing with new referrals. So that would be based on lots of different community settings potentially. So GP surgeries, community centres, things like that. And often that would be the clinician being the first person to screen or to assess somebody, a new referral that's the first time they've perhaps ever seen a speech and language therapist, and then we would do some assessments and then kind of triage the child rather, and then be giving some basic advice and recommendations and kind of developing a follow-up plan. In one of my other settings with another clinician, it was a preschool nursery setting, and it was a specialist preschool nursery. So these children had already been identified through their mainstream nurseries or perhaps by their parents, and they were coming to a specialist setting which was attached to a primary school, and in that setting they had specialist teachers who had advanced kind of training in communication. There was specialist teaching assistants, and then obviously speech and language therapists as part of that provision in the class itself. And these were children who were potentially being question marked for diagnoses of autism, global developmental delay, developmental language disorder, things like that. And these children would be having nursery sessions which were longer than a typically developing child would have. So they'd be kind of being dropped off at the same time as a typically developing child, but we would be keeping them for longer so we could have more time to kind of develop their communication skills going forward, which was really nice. You would be doing things like informal assessment, lots of kind of structured player-based tasks. And again, it was a chance to kind of work with a small group of children, but on a very intensive basis for, say, kind of a third or a half a day, which was really quite nice. And then working with the teacher kind of there and there rather than just kind of pulling a child out of a class and then feeding back. So I was kind of doing sessions with the teacher and the teaching assistant as well, which is really nice. The final part of this community paediatric placement was the more general caseload in terms of community paediatrics. So I'd be going into several generally primary schools, and I'd be working with a small caseload of children which were attached to my clinical supervisor. So I got a chance to kind of observe her doing the sessions initially, and then we would, myself and my peer would then be doing our own individual sessions. So we were going into the school ourselves and perhaps doing the therapy. So I worked with a young boy with severe developmental language disorder and apraxia of speech. So again, I was kind of used to working with some of the children who had quite significant communication difficulties, and then another child with some articulation, so some speech sound difficulties and a phonological delay. And then I'd be kind of going with my peer to her schools, and I'd be observing some of her sessions as well, which was quite nice. One of the last things that I did on this placement, which was quite nice, and it was during a half term actually, where because the children weren't necessarily in school, you might be thinking, what does a speech and language therapist do necessarily? Well, within this trust, in this particular team where I was doing my placement at the time, what they did during this placement, during the half term week, was they offered specialist stammering workshops during the half term. So they invited a small group, I think it was just all boys at that point. They were all kind of like 7, 8, 9-year-old, something like that. And over the course of 3 days, and again, these weren't full days, but it was kind of the most of a day because they technically were on holiday. Several clinicians would be kind of running workshops around stammering to give them techniques to support them, to perhaps give them a bit of advice, or to kind of improve their kind of well-being around stammering, because again, it's something that a lot of the children had quite negative perceptions of, or they felt it was a negative thing. So it was kind of taking ownership of it and in seeing as kind of part of their identity potentially. So it was quite nice to see specialist clinicians working with stammering, and then these kind of almost one-off workshops that they kind of developed and delivered periodically. So it was really nice to kind of be involved with that during my placement. So moving into my 4th and final year at university, I had my 5th placement. This was an 11-week placement for 1 day a week, and this was by myself, and it was actually in a clinical area that I've been asking for several years now. So it was in a child and adolescent mental health service, so an inpatient service for generally teenagers who had been sectioned under the Mental Health Act, and these were kind of children with diagnoses of autism, learning disability, and obviously mental health diagnoses as well. There were several wards there, and one of the wards was a secure unit as well. And because of the nature of the hospital itself, you often had children from the wider region, but also children who, because their local areas perhaps didn't have such specialist services, were being brought to this hospital to receive specialist help from the multidisciplinary team. So this placement was quite a special placement in some ways. So it was almost split in two. There was a clinical aspect, and then there was almost like a mini research project attached to it as well. So for the clinical side, I was allocated to work with a particular child by my clinical educator. So I did lots of assessment, trying to get to know this child, and then doing some therapy with them as well. I attended group therapy sessions with other children within the hospital and was kind of doing other clinical tasks as well. Like my previous experience in the stroke ward, I got lots of opportunities to shadow members of the MDT, but this time obviously a wider range of multidisciplinary colleagues, obviously psychologists, psychiatrists, people like that. The second part of the placement was that kind of mini research project I was talking about before. So it was called a service delivery project, and this is essentially where the speech and language therapists at the hospital had a clinical question that they thought would really need to be answered, and the student coming in this case me, supported them to kind of do the hands-on work around it, and then end up writing a report. So what this involved, or what they were kind of interested in kind of answering, was the children in the hospital had lots of what we call care plans. So me as a clinician, I write a care plan saying what I'm doing with the child and why. And what the speech and language therapists were interested in was how involved were the children themselves in this care planning process. Was it a case of a psychologist or a psychiatrist just writes a care plan and they're just kind of not really involving the child in it too much, or maybe does the child just not understand what's involved in that care plan? So did the child agree that they needed to be given some medication to help them manage their emotional difficulties or their hallucinations, things like that? From a psychological point of view, did the child agree to a care plan to manage their challenging behaviour? So that might involve things like restraint or kind of a debriefing process further down the line. Or was it a case that the clinicians were almost just writing it up formally and it existed on the computer system, but the children themselves either had no clue that it existed, or they had some vague notion but they really couldn't recall it, or they didn't really understand the care plan. So what this looked like in practice was selecting a number of children from the hospital, so a small sample of children from each of the wards. I would then read each of the care plans for each individual child. I would make accessible or speech therapy versions of those care plans themselves. I would then go and interview each child individually and try and get a sense of, are they aware of the number of care plans they've currently got? Which kind of disciplines might these involve? So things like, do they know that there's a nursing care plan, maybe around their personal hygiene? Maybe there's a psychological care plan because they're receiving one-to-one therapy from the clinical psychologist, for instance, that sort of thing. Some of the things that I noticed by doing this was that the children who had the more severe clinical presentations, so maybe they had say autism, a moderate learning disability, or perhaps a history of being in care, lots of kind of developmental issues potentially as well. They were the children who tended to have more care plans compared to some of the milder children, or children who perhaps had had a less persistent difficulty, maybe it was just kind of things in their teenage years rather than kind of from birth. So those more severe children tend to have more care plans. And then in terms of the individual care plans themselves, the more severe the children were, the longer and more complex some of these care plans were, because again, you can imagine if you're a psychiatrist or a psychologist, sometimes it just takes quite a few words to describe what your hypotheses, your clinical thinking around something, and it's not something that can necessarily be captured quite easily. So those children tended to be less involved in their care planning process. So from my point of view, I would be then trying to use some of the speech therapy resources to try and improve their understanding. Sometimes this helped, but not always. What was really interesting about this project was perhaps the wide scope of children that I managed to interview. So in some cases, it may be, say, interviewing a young girl who is actually quite involved in her care planning process. So perhaps she knows explicitly the number of care plans that she's got. Maybe she's almost kind of co-written one of the care plans with, say, the psychology team. She's been explicitly telling them that actually group therapy sessions are not a thing for her. That's not helpful. So her preference is very much for doing individual sessions. Maybe she's selected a particular day based around her studies that she's doing in the hospital as well. And then comparing that to someone perhaps at the other end of the scale where I physically couldn't get onto the ward with them because they're not safe to be around other people, so effectively they're living in long-term segregation. Maybe there's someone with a diagnosis of autism or a moderate learning disability, and I'm almost kind of conducting the interview on the floor, sliding things underneath the door, and it's almost just kind of confirming that even with the support of a speech therapist, it's really, really difficult to engage some clients in that care planning process, and ultimately we need to be kind of making a decision in that person's best interest, because generally they are lacking capacity. So it's thinking about, can we make sensible decisions in their interest and try and make things accessible, but acknowledging that there are limitations to what we can do. The last thing I want to just comment on this particular placement was in terms of individual travel or commuting from one place to the next. This was by far the kind of the furthest I had to travel. So from my home to the actual hospital itself, it was 39 miles one direction, slightly short if I kind of went the back roads, but not necessarily saving any time from that. So it was kind of 78, 80 miles there and back. From my point of view, it was worth it because, again, it was a placement that I was really, really interested in terms of mental health. I felt like that was an area of clinical practice that I felt kind of myself gravitating to in some ways. The commutes were tricky, and again, I was doing this at a time of the year where it was getting quite difficult to commute. There was snow at certain points, so my travel was delayed on particular days. But for me, it was a placement that I thought that kind of commute, that extra effort, was definitely worthwhile. And again, I felt I learned a lot from that. So it was definitely worth it. So my sixth and final placement was another community paediatric placement. It was another block placement, so 6 weeks, full-time hours. Like my third year placement, I was split between 3 educators. It was also another peer placement. So again, I was with another an undergraduate student. Again, this was a different undergraduate student and one that I knew quite well, and it was a chance for us to work more closely together, and I felt we kind of worked really, really well together. There was some similarities in terms of the kind of the content or the structure of the placement compared to the one I completed in my third year, but there were some differences as well. So one of my days was, like my third year block placement, it was a community assessment or review clinic. So children coming in for the first time, or perhaps we're following up with them a little bit further down the line. The main difference would be that this placement was geographically a little bit closer to where I lived, and I was someone who was local to the kind of that area generally, so I found kind of building rapport with the parents really quite easy, to be fair. Again, I was of a similar age to some of them. I had my own child as well, so again, I found that process quite easy in some ways. In terms of the other days, I was split between the local NHS trust, and then what made this placement slightly different to the previous block placement was that part of my placement was with a speech therapist based in an academy trust rather, and this academy had kind of a preschool or nursery that was then feeding into primary schools, which was then feeding into a larger secondary school. So it was made up of lots of different schools, and I was shadowing and kind of working with the clinician, and their job was kind of spread across all of these different schools. So I'd be kind of going into the preschools that they were working in. I was also going into the primary schools on certain days, and then also the secondary schools on the odd occasion as well. So that made this placement quite an interesting one from a kind of a service delivery or a practical clinician point of view, because I was in some cases going into the same school but with a different hat on. So on one day I might be kind of with my NHS clinician going into the Academy Trust because all the children are still eligible for speech and language therapy through the NHS. Perhaps kind of reviewing what's been done by the teaching assistants or the kind of the wider speech therapy team. And then on a different day, I might be with my academy speech and language therapist within that same school trust. And I'd be the person in charge of doing the therapy that I'd kind of previously just reviewed, maybe earlier in the week. So there was kind of close collaboration between the NHS and the speech therapist who worked as part of the Academy Trust. But it made it quite tricky at times because it was very obvious that the provision provided by the NHS in some cases wasn't sufficient for some of the children's needs. And then the Academy Trust were effectively paying their own speech therapist. But because the Academy Trust was so large, and that kind of area that the schools were in was one that was kind of socially deprived in a lot of ways, the need for speech therapy across the board was quite significant. So even with the extra speech therapy that they were kind of almost paying for, it still really wasn't enough. So you were kind of seeing gaps in service provision all over the place. Some specific things that perhaps make this placement different to the previous block placement, because again, there were definitely some similarities, because again, it was still a community paediatric placement, and I did have some initial reservations about that. I was hoping to have a placement, again, perhaps a little bit aligned to the previous one in mental health. So again, maybe say like a community learning disability one. So I did, again, I'm going to be honest and say I did have some reservations and did wonder what I'd be kind of learning from this. So on reflection, I think what I definitely got from this that I didn't get from my previous placement was, because the Academy Trust involved a secondary school, I'd never worked from the NHS point of view with children in that mainstream kind of setting. Obviously the psychiatric side, yes, but in terms of how does, say, a child who hasn't got significant behavioural difficulties, how are they managing to get on in a normal secondary school? And obviously the answer is not always fantastically well, unfortunately, and perhaps going and doing a bit of assessment and trying to find out how best to support that child, but then not necessarily having the resources to do much more than that. So it is just more signposting and giving the teachers some advice, because again, from their point of view, they're seeing a lot of these issues perhaps that should have been already resolved in the primary setting. Another aspect of this placement, and again, because we were in our final year and we were doing a dysphagia module alongside, all of the students, regardless of their placement, had to have some dysphagia in it. So there was an observation day where I spent some time with a clinician who worked in the kind of the adult community team in the region, and I kind of met up with her, and outside someone's house, effectively had a bit of a chat in her car, and then we kind of went into the person's house and effectively kind of assessed their swallowing and kind of saw how they were getting on. Had a bit of a chat afterwards, and then part of my assessment for that dysphagia module was almost kind of writing a bit of a write-up of what I saw, what was the rationale from the clinician's point of view, would I have done anything different, that sort of thing. So that was like a one-off session that was organised by our clinical educators to meet the requirements of that dysphagia module specifically. So it didn't really have any kind of bearing on the rest of the community peds. It was just kind of like a one-off session, but again, it gave me kind of a chance to revisit some of that dysphagia stuff that I hadn't really done at all since kind of working on the stroke ward in my third year. And I suppose the final learning point, or the final big difference between this community paediatric setting and also perhaps the one in my third year, was that kind of gradual step up in terms of not necessarily the complexity of the children, because I think some of the children were perhaps more complex in my third year, but it was definitely perhaps the practicalities of service delivery, in terms, like I mentioned before, you're very acutely aware of what some children need but then can't get in terms of access to specialist provision. And also from a service delivery point of view, I'd be the point of contact. I'd be doing the initial assessment, I'd be then doing the therapy, and then perhaps writing up the review or discharge report as well. So kind of as I was coming towards the end of my course, kind of taking ownership of that whole kind of clinical pathway, if that makes sense, or that whole that kind of journey that a patient or a client might go through potentially. And the other aspect perhaps worth mentioning is that the number of children on my caseload was again gradually getting larger and larger and larger, and your time management skills were obviously being taxed at this point as well. So you were kind of expected to kind of do notes kind of very quickly and kind of move on to the next child, write up your reports quite quickly, and then obviously then feeding those back to your clinical educator so they could provide some feedback. From a practicality point of view, this placement was actually perhaps the one that was closest to where I lived, but still involved kind of travelling 20 to 25 miles, depending on which base I was on the day. So kind of the return trip would be anywhere from 40 to 50 miles. But because I was being a lot more independent and I was almost kind of managing my own little caseload, I'd be travelling, depending on the day itself, I'd be travelling between sites as well, like you would as a normal kind of community paediatric clinician. So perhaps doing more mileage than previous kind of placements, despite being kind of the closest to where I lived, if that makes sense. So there you have it. That's an overview of the clinical placements that I completed on my speech and language therapy degree. And you might be wondering about the thumbnail, and in particular the mug. So the mug is a present that I received from the young boy and his family in my second placement in the literacy clinic, and it's something that I've kept for quite a while now, to be fair. And again, it acts as a bit of a memento about my journey in speech and language therapy. And again, I always show, if someone showed appreciation to me about kind of the quality of kind of service they've received, I always take that as a positive. And again, I don't bin things like that. If anyone writes me cards or kind of buys me anything, little things like that, then I always do keep them as mementos, because again, it's nice to have these and to look back on in terms of kind of your future clinical career going forward. If you found this video useful, give it a like and subscribe to receive notifications about similar videos in the future. If you've got any comments or questions, then let me know in the comments below or get in touch with me on Blue Sky or Twitter. Otherwise, thanks for watching and take care.